to the Physiatry Mentors. I'm Dr. Sheena Bhuva.
I'm Dr. Benecia Williams.
And together we are Sheena.
I love it.
Yeah. So we are super excited for our guests today. Our guests are our very good friends, Dr. Nasser Ayyad and Dr. Keston Roberston. We like to joke and say that they are our male counterparts because you'll find out why. They both had very similar training as Benecia and myself. So they are new attendings who just finished their fellowship. So they're about 1 year into their practices. So we'll kind of discuss kind of they're more in the academic kind of hospital employed position. So we'll kind of go into more details about that. So welcome, guys.
Thanks, guys.
Thank you very much. Excited to be here.
We're so excited.
Congratulations to you guys for doing this. Giving back.
Yeah, it's definitely a medium that we needed.
Thanks, guys.
Yeah.
We appreciate
it. You guys saw
it.
this opportunity and you're like, you know what? Let's do it. It's been impressive.
We needed a reason to reunite Shenisha, so this was perfect.
Shenisha's giving back.
Yeah. She's giving back. So as Sheena said, so Keston was our PGY. I always feel like you're always my PGY too, because he was directly, and same thing with Nasser behind us. Keston went to residency, so he got to endure a lot of Shenisha. The very first day we met Keston, I will tell the story, was on a Tuesday, was our didactics day, and I always sit next to Sheena and everybody. I would sit to her right. Sheena was my left-hand man, always. So Keston, I walked into didactics and Keston's in my seat. I was like, you're gonna have to roll on up, homie. Like, I'm gonna need you to get out of my seat. He was probably like, who is this person? But after that, but it's all love. Yeah. And then Nasser and I actually went to medical school together. We're TCOM alumni. He was a year below me, and he went to residency right across town at UT Southwestern. So we got to do a lot of cross stuff, and we played each other in a couple football games throughout Powder Puff. And
actually, as I was thinking about this today, I had these flashes across my brain of Benecia with her eye black on, this really serious look, and I come out, I'm like,
who is that?
This is not the Benecia that we're used to.
If I'm gonna do it, I'm gonna do it.
Benecia. This is the real Benecia.
I was serious, I'm very competitive.
They definitely taught us a lesson.
Oh man.
So I alluded a little bit about your guys' training, but Keston, why don't you tell us a little bit about your educational background, and then I'll pass it to Nasser.
Sure. So Keston Roberston, I grew up right outside of Washington, D.C., went to Morehouse College in Atlanta for undergrad, came back home to D.C. to do medical school at Georgetown, and then became an honorary Texan. I thought it was going to be temporary, but 2015 came down, did my residency at Baylor, Dallas, and Dr. Bhuva and Dr. Williams were my PGY 3s, as I was a 2 when I started. Then after finishing residency, went to John Peter Smith for fellowship in sports medicine. Got to work with TCU's football team, some smaller Division II schools as well, and some high schools there as well, before kind of circling back and rejoining faculty at Baylor and opening an outpatient sports medicine practice.
Great. What about you, Nasser?
So my route was a little more circuitous, a few more turns, a few more U-turns along the way. But I went to undergrad at Texas Tech at Stephen F. Austin and worked for several years before I attended medical school. I did a big U-turn because I was an international business major. For all the non-traditionals out there, it's definitely possible. Worked for several years, and one of the jobs I had was in the pharmaceutical sales area. And one of our opportunities was to go out and follow a doctor when you got started in your territory. And I realized, like, within the first few minutes, I was like, ooh, I could do this. But it required a lot of, as we know, all the prereq courses, a lot of hours. Eventually applied, got into TCOM to UT Southwestern, and then, as Sheena mentioned, did my spine and sports training at Desert Spine Sports. So shout out to Brad and Susan.
That's right.
In Phoenix, and now at UT Southwestern.
And I do have to make the announcement that Dr. Omar Salat is now watching, and he says Keston looks so good in Cowboys blue.
Oh my gosh. I will, due to my employment restrictions, I will not tell folks how I feel about that statement.
You're in the backyard, aren't you? You're actually
I am. I look out at their practice facility.
That's right.
So I'm going to try not to. Again, I said I grew up in Washington D.C., so somebody could know where my rooting interests probably lay.
Yeah.
But
I'm curious to know what's the new mascot. Not to get into all that.
Yeah.
What your vote is.
I think I'm okay with Red Wolves. I mean, I don't know. Yeah, like I know they're saying Red Wolves, Red Tails, like keeping the red in there, I'm okay with. So whatever we change it to, I'll adjust to it. It's fine. Just the name. The team is what I vote for. So.
Right. So as we kind of alluded to just now, Keston he works at the the Baylor Frisco location, was right next to the Cowboys training practice. And we'll kind of touch a little bit about kind of what it's like working in the DFW area, but I forgot to mention our intro that we're all, Keston, Nasser, and myself are within like 5 miles from each other. Keston is in Frisco, and I have a clinic in Plano and Frisco, and then Nasser is in Frisco. So it's really crazy with how kind of saturated it is, but even then we're still pretty busy. So you just have to kind of know your climate and kind of where you want to practice and kind of what it looks like there. So so you guys both returned to your residency programs after fellowship. Was that the plan that you guys had while you were in fellowship, and kind of when in fellowship did you guys come to that decision and kind of sign your contracts?
Go ahead, Keston.
Okay. For me, I know people say a lot of getting a job is like networking. My job kind of, I'm not going to say fell into my lap, but it was brought into my attention like through my residency program. So I started fellowship and roughly a month into it, the Baylor PM&R department said they were trying to open a sports medicine clinic at the Star, which is this big complex that Jerry Jones, the Cowboys, built to kind of, I guess, keep all their stuff centralized. But they have a professional association with Baylor, and Baylor wanted to have a PM&R presence out there, which they hadn't at the time. So they approached me about starting PM&R sports medicine practice. So this was around Labor Day 2018. And there was a long process to get to like actually staying on. So there were times where I looked into other opportunities, but this one kind of kept coming back with, oh, just hold on. We're kind of getting some logistics started, like starting up a practice from nothing. There's quite a bit of work to it that I was not so aware of initially. But to answer your question, was it the plan? I don't know if I had a plan. I think you guys can attest. I'm pretty much a go with the flow kind of guy. Like I always feel like the right opportunity will present itself, and I just have to be open to it. So in talking with them, they kind of lined up a lot of the career goals that I had for myself in selecting that job. So it ended up working out. Like it ended up giving me the most of what I want in relation to some of the other things that I could have potentially done. So no, it wasn't the original plan, but yes, it ended up being the best plan for me, I think.
When in your fellowship did you sign your contract?
Oh man, so I told you we started in like September. I signed my contract in June, like not late June, like mid-June 2019, after our first conversation in September of 2018. Yeah. So it was a lot.
That's a long process, that's for sure.
It was a long process. And I know we had discussed, obviously, we're all good friends, so we know you were weighing all your options. So It was late, but you had options.
Yes.
So that's what it's like to be, first pick, you get to.
It was.
Five-star recruit.
Five-star recruit.
I don't know about all that, but no, there were some awesome opportunities. It was very close to doing other things that would have been probably equally as good, but I got lucky, and this has been a good opportunity so far.
Exactly, like you said, it's a good fit for you. It aligned with what your career goals are. So
yeah.
All right.
We're lucky to have you.
That's for sure. Thanks, man. Look, man, I can't look. I'm wait until they hear your story, man. I'm just trying to try not to get blinded by the light, which is my boy, Dr. Ayyad, man.
I know, right.
He truly is the man. Like, and she said 5-star recruit. If we're looking at one, he might have been one in football and in medicine.
No,
So,
Yeah, he didn't mention that. He played football in college.
Just scratching, just grinding, man.
Yeah.
All about the grind. Everybody knows.
For sure, yeah. He's being humble, folks.
Yeah.
Very,
Not really,
very
not
humble.
really. So similar to Keston, I didn't necessarily, this wasn't the plan per se. Actually, it was not the plan at all. I didn't suspect I'd be coming back, and not because UT Southwestern or the group I work with isn't a fantastic group, but just I had my ideas, or my mindset was in another direction at the time. And as I started doing the different interviews, I got a call from the Spine Center at UT, and they shared their opportunities and growth. And I said, I had a lot of respect for the members of the team, particularly PM&R members that I trained under in residency. So I said, well, let me go listen and hear what the plan is and what their vision is. And I contrasted that with all the other opportunities that I had on the table. And it became very, very clear that this would allow me to grow the most and be surrounded by people I thought that had the same vision I did in terms of how to practice medicine, how to practice spine and sports, MSK. So it was not the plan, but it's one of those things. You go into the interview and you think, let's see what happens. You walk out like, I think I'm going to go here. Like, I think this is what's going to happen.
Yeah.
So, and I ended up signing my contract April, May. I will say, for anybody who's kind of out there right now, give yourself time. Mm-hmm. So Sheena and Benecia both are go-getters. They get on it. And I think they have clear visions of what they want. Benecia knew she was going to work with Dr. Salah. And I know she had a couple of variations, but I remember you saying that back in med school. And Sheena, I think, someone asked me when I started interviewing, like, I talked to Dr. Bhuva and she started like in October. Like, oh, yeah, not me. I started maybe in December, January, and I gave myself time. But
yeah,
I think it depends on if you know exactly where you want to go.
Exactly.
And Sheena, you had a geographic destination in mind, where mine was more of kind of like, let's look at the opportunity in a holistic manner. There's benefits to both, but I gave myself time. I think every field is different. If you're not sure exactly where you want to be and you want to figure out what your options are, give yourself a little time. Yeah. I think if you sign by late spring, you're fine.
How long would you say it took for your credentialing? Because we had kind of talked about this before. So if that delayed it for you guys at all? Your start, when you thought you were going to start. If you signed in spring, when did you guys actually start because of your credentialing?
So I started September 30th. So it took me about 4-ish months to get everything together. And I already had my Texas medical license. I already had my DEA number and all that. But there is a long, at least in my process, there was a time that it took to get you on insurers, to kind of go through all the process of credentialing. Like, I know Baylor's credentialing committee, I think, meets like once a month. So like, depending on when you get in, like, they might try to rush things through if they can, but it's still a process. So it took me about 4 months. So I finished fellowship in July and had almost 3 months where I was hanging out at home.
It's amazing, right?
Yeah.
Like the best 2 months of your life. I remember having 2 months off and I was like, dang, should I take another month off?
The answer is yes. Yes, if you can.
Take as much time as you can.
Yeah, take
I was on vacation. Go ahead.
And I was just saying, yeah, take advantage of that time off in between, fellowship and your job.
I think it's important to also set expectations, if possible, early on in your discussion with your potential employer or potential partners about what your vision is after fellowship. So there's no surprises along the way. So if you want time, and of course their interest is to get you in place as soon as possible for understandable reasons. However, let it be known early on, so it's not something you're negotiating later on, that you want time. And I think that's important. I wanted time as well. I didn't start until I had kind of a different type of start. I started September, took October off, and then came back in November just due to needs we had here at UT. But make that known.
Yes.
That will be easier moving forward. It's like anything in life, right? You set expectations earlier and the discussions are easier later.
To your point, Benecia, you know, I'm sure some of our viewers know that both Benecia and I, we signed our contracts back in December. And so we were able to, and this was our choice, right? We started in August. I started last week of August.
September, first week of September. Yeah.
Yeah. And so we had, you know, all our credentialing, everything was good to go. And, you know, there weren't any hangups or anything with insurance once we got started. So.
And if you're in Texas, give yourself time.
Yeah.
It's different right now. I know things are different in terms of how they're being
right. Yeah, it takes time to get your Texas.
If you're in Texas, give yourself time
to
keep on practice here. Yeah, it's intense.
It takes a long time. Texas medical license itself takes a long time. So we all happen to already have ours. So that definitely helps speed along the process.
For sure.
So yeah, for sure. So at PM&R Fort Worth, we have a lot of medical students. Omar is excellent with taking students and residents. He usually has a posse of like 4 or 5 people with him at all times. So the other partners were getting better at taking on more students. So how's it been for you guys transitioning from a fellow to an attending in an academic setting and having residents and having to teach? And then did you guys do that from like day one?
Nasser, go ahead.
So part of my responsibilities is we have a spine clinic at Parkland, and I'm one of 2 attendings that staffs that clinic on Friday afternoon. So that started from day one. And coming up and starting, I guess actually this last week, I have a resident in clinic 1 day a week, and we'll have a fellow in clinic 1 day a week on the UT side. So it is a true blessing to have the residents, to have the resident clinic for a lot of reasons. Number one, it makes you better. It's a selfish thing. You get better. You got to bring your A game to the table. So you're learning with them. I try to do a lecture every kind of rotation. There's residents that do lectures, so I learn from theirs as well. And then in addition just to the medical and academic work, you know, just how you build those relationships, how you communicate with people, those are all skills that all of us are always working on, right? So yeah, it's like anything, right? You get better. You get better in these types of relationships. And that was one of the attractions for me going into academic medicine, particularly at the beginning, because I know, you know, in order to be a best, you got to continue to improve.
Yeah, for me, it was interesting. So like I didn't start taking residents until recently. So in a new clinic, it was a build-up time to get enough volume. Like I didn't want to bring a resident in and just kind of like, if we had a slow day, they're just kind of watching me do nothing or something like that. But I just had my first resident. It was actually for 2 months, and I had one of my former co-residents. She was my PGY2 as I was a PGY4 at the time. So she was going on her senior rotation. She'd already accepted a job. And I tried to structure the rotation in a way that would be valuable to her going into the workforce. Because I remember there were things that I wish I knew. So I told her for my rotation, in addition to seeing patients when we have some downtime, tell me what you want to know about. Like, what do you feel fuzzy on? What do you need to like hone before you go out into practice and do things? So she kind of helped steer that part. I mean, in addition to helping me see patients when we were in clinic, we'd sit down for a little bit before or after clinic and go over a lecture like, hey, let's talk about common knee pathology. Let's talk about how to do this injection. Let's talk about what your differential should be when you're working up a shoulder in various stages, that kind of thing. So at least in that experience, she said she found it helpful. I mean, maybe she was just being nice, but what I ended up trying to do is just tailor what in your practice, or what are you gonna need to know for when you go into practice later, and see if I can help kind of guide them along. But my sample size is, I guess, smaller because I just started working with residents, but I think that's probably going to be the way I'm going to go about it. We're going to see patients in clinic, and because I'm only taking 4s or senior residents at this time, basically, what can we do to get you into practice and feel as comfortable as you need to feel when you're out on your own?
Nice.
I think that's a really, really good point about customizing it. So the residents we have are going into peds, for example. So what in spine clinic can they get most value from? So do we talk about scoliosis versus, kind of the more, rather than some of the more degenerative cases? And of course, they need to know that as well for overall education, but really hone in on that during their one-on-one time with us. So I think that's a really good point.
Sure.
And everything that you said you wish you had, you've got to back it up now.
I know, no, there is pressure on it, man.
I know you're like, they should have done this, they should have done this, and you're like, man, I got to back this up.
I know. It was always so easy as a resident too. When you saw your attendant, it was like, man, do they know that they should have probably been doing this, this, and that? And you're like, all the while, I'm like, am I doing the right thing? Like, I want to make sure that I'm not teaching somebody the wrong thing. So
Exactly. Yeah.
I know. Yeah. It's a lot of pressure. Whenever I have a medical student, I'm like, oh my God, let me make sure I'm not. I'm like, this is going to stick with them forever. So you don't
exactly. Like Nasser said, it makes you a much better physician. So,
yeah,
I think all four of us, we really enjoy teaching and we find it very rewarding. Benecia and I are in private practice, so it does take time, right, to be with a student. It does take time out of your day, and that eventually can decrease maybe your revenue, when you come to the bottom of it, right? Because you're spending time with the patient, with the student, and you're not able to see as many patients. So
unless the only caveat is unless you get really good at it. And like Omar sees a very high volume, and he prefers, it makes him faster because he's like, I can sit a student here. I'm like rotating. So maybe one day I will get there, but.
And a shout out to all those.
He's a rock star, so I mean, I can see how that happens.
Shout out to all those attendings that we've been with. A lot of us have had similar attendings, like Omar, who I think about his format and how he used
exactly.
How to utilize medical students, but at the same time providing value. And that's the key. No one wants to feel that they're there just to make the practice better.
That's an excellent point.
No one wants to feel that. And the good ones know how to do both, right? They want to improve efficiency,
excellent
at the
point.
same time really providing value. Brad and Susan Swarovski and all the other attendings at Desert were the same way. We realize, and it makes you feel better too, because you're like, I think I'm not at least dragging the practice down, but I think I may be adding value myself. That's true or not, who knows? But it's a good balance, and one that I think
you miss the good ones when they're gone. Like the ones that you're like, not only was it fun to teach, but it didn't make my day feel like it was slower or worse. Like it's hard to strike that balance, but if you can get taught and also, I don't know, kind of help things run more smoothly. That's one of the pieces of advice I got as an intern. How do you make your seniors' life easier? How do you make your attendings' life easier while also getting the information? Like you're not there to be, like you guys said, just somebody to write notes or kind of tag along or take up space. There's value of all students and residents to a team, but you can also you can get stuff out of it while putting stuff into it. I guess that's what I'm trying to say.
Yeah, definitely. And oftentimes,
Sheena, are you taking students, or do you teach?
I would love to eventually, Benecia knows this, maybe have like my own kind of fellowship. I think I've talked to you guys about this too,
She would be so good.
She would.
And the good thing is about Texas Back Institute, we actually have a ACGME spine surgery fellowship. So we have 5 spine surgeons, every year. And so they get to spend time with me in clinic and kind of in the injection suite and kind of learn about what PM&R does. So I love that, but I would love to also kind of teach PM&R, students or people interested in PM&R. So
I'm always like, Sheena, can I be your fellow?
Fundamental.
It'd be so good.
Collabo with UT Southwestern right up the road. They're right up the road. So.
And as we, teaching is very, I don't think it gets a lot of recognition, right? And we don't often get paid for it. So I'm curious, with you guys being in an academic, like a formal academic setting, do you guys have a stipend, or was that built into your salary when, you guys were negotiating your contract?
So no, like for me, it's not. For me, it's not built into my salary. They did ask, I did have the option to not teach. So it wasn't like because you're on salary, because you're on faculty, you have to teach. It was definitely optional. I chose to do it because it was kind of one way I thought I could give back to our program a little bit. But it was optional and I chose to, but I didn't get any extra stipend or anything for it.
So in terms of our structure, it's somewhat both. So it's really built into some of your responsibilities, but we do our reviews or our bonus structure, part of it is, are you fulfilling your academic responsibility? So we do have certain bonus tied to that. So if you're not, for example, yeah, it is. I would say with that being said, that's, for me personally, that's never the motivation, right? I kind of try to just think of, how would I want things as a resident, as a medical student, and even medical, we have medical students that come to our clinics, and as you know, Benecia, like, they're paying to be there. And I always keep that in mind. Like, you're not getting paid to be here, you're paying to be here. So you should get value out of this expensive medical education. So I really try to think of it in that way, where, how would I want to be treated here? And I think, it's all about having valuable experiences, having valuable connections, and hopefully that's how we all get better, right? That's how we all get better.
Right.
So there is there is a financial piece, but I really don't think about that when it comes to those responsibilities.
While we're on this topic, Omar had a good question for you, Nasser. So
no.
how much, no, this is a normal, appropriate question.
Okay. Right.
So being at UT Southwestern, which is a large academic center, do you have any pressure to actually, participate in research and, come up with publications?
Yeah, so there's a couple of tracks that we have within the PM&R department. So you can have more of a research track or more of a clinical track. My natural inclination is to do more like community outreach, for example. So I would like to be involved in research, but just my natural personality, that's never going to be the mainstay of what I do. I think my tools are better fit for other activities. So for example, right now, I'm leading an initiative to start a community spine lecture series with our spine center. That we want to roll out as part of a UT Southwestern / Spine Center initiative. So that can be used as a almost replacement or or for research in my case. At least that's what I've been told, and I'm running with it. But at the same time, the blessing is we do have a lot of resources as well. So I will be involved in research, but the resources are there to take off some of the heavy lifting. Now, if you are research heavy and that's where your passion lies, we have a separate track that you can go into and fulfill those desires or those interests as well. So you can go either a clinical track or the research track. I know that my chairman, Dr. Bell, if she was listening, she would say, yeah, you have a research obligation, right? But they're not unreasonable. They're not unreasonable.
That's awesome. I know Sheena kind of had alluded to it, but UT Southwestern is now starting a new spine fellowship. And your first fellow starts in August. I literally just found this out like a week ago. I was like, what the heck? Tell us a little bit more about that, and how was it setting that up?
So we're super excited. We have our first fellow starting in August. Her name's Esther. I think she's going to be fantastic. And we have everything you really need from a spine MSK approach. We have a huge spine center, which is, the way we work. We're a multidisciplinary team of neurosurgeons, orthopedic surgeons, PM&R, and anesthesia. And so then we also have access to our PM&R sports medicine doctors, who will provide a lot of the ultrasound experience and other MSK experience. So the credit really goes to Dr. Ankit Patel. He led the initiative. The beauty of this fellowship is that we're really customizing it for each fellow and their interest. And so if they want to be very spine heavy, we'll do that. If they want to do a little more ultrasound, a little more spine, and throw some EMG in, we'll do that. So that's the beauty of it. We're really going to be able to customize their experience because we have all the resources. So I'm excited. This is truly just about providing a really good experience. We're NAS provisional year one. So credit again to Dr. Patel and the team that helped roll that out. And we've already started interviewing, securing for our next year. So I think
That's
it's going to
really
be great.
exciting.
I'll spend a day or half a day with a fellow in the beginning, and then hopefully increase that as time goes on. And I think it's going to be a great program. And hopefully, as time goes on, we'll be able to get more than one.
Yeah, no, that's awesome. So
We have
now
the
at
resources for
UT,
it.
yeah. So at UT Southwestern, there is a ACGME pain fellowship through
Right.
anesthesia program, and now there is a NAS provisional. Hopefully you'll get there. I'm sure you'll get it soon. Approved non-ACGME fellowship.
Yeah, and it's an interesting conversation to discuss, the benefits of each. They both have benefits, right? But I think the experiences will vary a little bit, and it kind of allows people to go in the track they're interested in.
Yep.
Right.
That's our episode 4, guys. If you
We'll call in.
Episode 4. Yep. All right.
And
so
can I ask this question real quick too? I know it wasn't on there, but I know will probably be asked. Since I know we all do procedures, did you guys have any difficulty, Nasser, doing non-ACGME, getting credentialed to do procedures at an academic setting? And then, Keston, did you have any problem being credentialed to do as a sports medicine fellow, board certified?
For me, no. They just asked for my procedure logs and fellowship. I did not listen to the advice of my senior, Dr. Benecia Williams, who said stay on it every month. So I had to go through the end of my schedule and went through every patient that I saw and every.
You didn't learn through residency either, Keston. I think you did the same thing. You waited last minute.
I told him, I said, Keston, I said, you're in her fellowship. I said, just do it once a week. I said, do it once a week. It's going to be, I said, do not wait until the last minute. I said, it's going to be crazy because you're going to have to pull up the entire year. And that last week, what you're having to pull up the entire year.
Opened every single patient's encounter that I had for a year and logged my procedure. But yeah, after I did that, that was the hardest part. I sent that off with my credentialing stuff. And they approved everything I asked for as far as procedures. So,
it's a really good question because I didn't know what it would be like. And the impression I had was going to a non-ACGME program that it may be a challenge. I would say that of all of the people that I spoke to, recruiters and interviews I went on, there was only one that required an ACGME back program. And so everybody else, now I don't know if it's the reputation of the fellowship, at Desert Spine Sports, or just that things are changing. I think previously it may have been more of an obstacle, but it wasn't an obstacle at UT Southwestern. And I kind of felt like, well, if I can get privileges here, then I should be good.
Yeah,
right.
I assume that's the case. And,
absolutely.
From kyphoplasties to your simple epidurals, full gamut.
Right. And UT Southwestern obviously is a huge academic program. So hopefully that answers the question.
Good question, though.
Yes,
Yeah,
thank
good
you.
question. Yeah.
All right, so this next one will be fun. So, like we've mentioned many times in this talk, Benecia and I are in private practice. You guys are, in the hospital, kind of hospital employed academic setting. So what are some of the pros and cons of the setting that you guys are working in?
I'll say mine, given the COVID, it's like, if you don't see patients, you don't get paid. I'm like, and that's what I know. I talked to Sheena the other day. I was like, well, I made very little money today. But then some
numbers
days,
are going back down.
Yeah, exactly. And then some days you are very busy and you make a lot of money. So it just is variable, especially in our current climate with COVID. It's just crazy. I think everyone's seeing a reduction in pay across the board.
I agree. Yeah. And I made a post about this on one of the Fridays, but looking at like my value, like what my production, what my work RVUs were. So compared to like a normal month in October, my April, which was all telemedicine, had gone down 80% production. So my salary went down 80% that month. But thank goodness for, Benecia and I, we both applied for the PPP loan. And so we got that. So that kind of helped a lot, but that's definitely something, I think we have a lot of autonomy with our schedule. So if we want to go on vacation, we can take vacation. We don't have any vacation, like a set number of vacation days. It's just if you go on vacation, you don't make money, right? So you can take 2 months off if you want, but just don't, during those 2 months, you won't make money. So there's a lot of leeway with it. It's nice, if I need to take a long weekend, Friday, I don't really have to tell anyone. I can just block my schedule. So there's a lot of freedom in making your schedule, which I think I appreciate, and I know Benecia does as well. But there are some cons as well.
Yeah, absolutely. So. Yeah.
Yeah.
And we pay like when we pay our overhead and stuff, like I think the difference, we see where every single dollar is going. You're like, oh my God, you're like, I spent that much money. Yeah, exactly. Like when you get your bill for our malpractice, it's like that bill, I have to cut that check where you guys probably don't have to.
Your insurance, right? Health insurance. Yeah.
Yeah.
And your health insurance is probably a lot cheaper than what we have to pay. So yeah, it definitely is pros and cons to both.
For sure.
Like if I was salaried, I'd be like, well, sorry for you.
So that is a small blessing, I guess. Like I am salaried for my first 2 years of my contract before I go to production. So luckily I hadn't seen a change in pay, despite like Sheena, my volume was down probably 80% as well. Like I wasn't seeing anywhere close to what I was bringing home, but I mean, as part of their contract, I guess, I was able to continue to get paid. Some cons, I don't have nearly the flexibility that to just say I'm gonna take off, or I can, like I have a set amount of days I can take off a year, but I have to tell somebody. I try to tell people with reasonable notice, so like they can make arrangements and reschedule patients and things like that. I don't hire my staff, so everybody who's on the staff with me was hired by Baylor. I kind of just have them. There are some, the benefits, like you said, I don't know what I pay in malpractice because Baylor takes care of that. I roughly know what the overhead of the practice is because I sit down with my practice manager and talk about it.
You pay about $6,000 a year.
Yeah.
So,
there's a decent amount of it. So I know what that part is. But there are some, like you said, like some cons. Like I think one of them is the flexibility thing. Like I'm not technically my own boss. Like there are people I have to report to, I guess. Like, yes, in clinic, I make the decisions. Like, I don't feel pressured to do one thing or the other. But there is a division chief and a department head and all these people that, you, again, have to answer to at some point.
I think those are all good points, and I echo all of them. I would say that, just backing up a little bit, not every academic job is purely academic. And there are some private practice models that are not truly private practice in terms of being a partner. And sometimes you're an employee as well. So there are kind of different variations or flavors of each. I would say, I'm definitely in a academic employee-based model, although I have a base salary and then a production on top of that, starting off.
Yeah.
So kind of a bonus on top of the base. Same thing you guys said in terms of like hiring. If I decide, hey, I could be so much more productive if I had one more staff member, I can't make that call. I can't, I can ask for it, but I don't have the final decision on that. So I would just say people who are out there who are looking, just know that not everything is purely like, I would say we're kind of in a hybrid model-ish, where a couple of days of my week are much more academic, and then a few more days of my week are more of a private base, but an employee type salary with a bonus on top. So that's one point. The point that the major attraction for me was, and I mentioned this earlier, is definitely in the beginning of my career, I wanted to continue to get better. And I felt the resource, and not that you can do that anywhere, any practice. I think that the major thing is just surround yourself with good people, and Sheena talked about her practice, and there's an academic slant to it. And Benecia, you're with great partners. And by surrounding yourself with really good people that you trust. And UT became top of the list quick because I just realized it was a type of medicine and practice that I felt comfortable with. And then spine, and then in MSK, there is a full spectrum. And at times, there's a thin line between legal and criminal. And I wanted to be way far from that line.
Yeah,
way far from that line. You're like, what is going on in this place?
Yeah.
I need this.
Yep.
I remember you calling me and you were telling me about an offer, and you're like, this doesn't sound right.
Money sounds good, but it may be a short career.
Right.
So,
right.
So where I'm at right now, like we have spine lecture series where I learn from neurosurgeons, anesthesia. We have journal clubs. We have all sorts of things. We have a gym downstairs. I learn from the therapist. So just a lot of great resources. I would just say wherever you do, make sure you're surrounded with good people that you trust and you can continue to grow.
And I think that says a lot about when you are at a program you train at and you go back to it, right? Because you're like, if it's a good program that you trained at and you feel comfortable going back, I think that just says a lot about the program.
I agree.
Right?
Yeah. No, I mentioned a little earlier, like one of the, I guess, pseudo cons of starting up a new practice is kind of having to build everything from the ground up, but that could also be like a pro. In my situation, they were like, hey, we have this association with the Cowboys. You want to do this sports medicine practice. What is a sports medicine practice? It was kind of almost that question, like, what do you want to do? Like, what do you need? So I asked for an ultrasound machine. I had that within like a week of starting. We asked,
that's a huge plus.
Yeah. Like I asked to do some interventional procedures a half day a week to start out with, and they said, no problem. So like they gave me a lot of room to kind of create the practice the way I wanted. So that can be a plus, like for all those going into a job search. It makes you so much happier to know that you're seeing the patients you want to see, the types of things you want to see. You don't feel, I mean, okay, you can't pick everything. Like there will be things that'll come into your office that you're like, man, this is not what I expected.
How did this sound like that? Yeah.
But I say all that to say, it definitely has increased my level of happiness knowing that the practice is what I want. Like I remember like ordering my own medicine to start. Like, you know, every clinic I've ever been in had Kenalog and betamethasone or whatever. They said, hey, what steroids do you want? What grapes do you want? Like what gel do you want? What ultrasound covers do you want? Like I got to do all that. Whoever, like if somebody comes and joins the practice with me, like I can, it's almost like a pride of ownership thing for like the start of it. Like this was, I remember when there was nothing in the closet and now we have all this stuff. So
that's awesome.
Yeah, it's a good feeling. I'm not saying it's easy. Like it would be easy to come in and swoop and take other people's patients or take over somebody else's patients, I should say, and work that way. But it's been a blessing. So
it's cool to see your practice grow, right?
Yeah. It's almost like the baby. Like
you're like, oh my God, it's your practice. Yeah.
Yes.
Yeah.
All right,
All right, guys. We have about 15 more minutes. We got a lot of questions to ask from the audience. Sheena's reading one. You want to start?
I'm reading, yes. All right, so Diana, she was one of the first ones to ask. So she says, thank you for sharing your experiences, Drs. Ayyad and Robertson. You both mentioned that academic medicine wasn't in the original plan, but what should we consider when deciding academic versus private practice? You kind of talked a little bit about that, but what normally draws people to academic medicine? Is there more protected teaching / research time, or fellowships recommended if you want to stay in academics? So 4 and 1. 4 questions in that one. So
I think we kind of answered some of them, huh?
Yeah. So are fellowships recommended if you want to stay in academics?
I would say you don't have to. I think there are generalists that go back and work in academics. And so I would say the answer is no, not necessarily. And if you look at the staff, probably it's half and half, across the board. I would say if you want to do a fellowship, just make sure that you have conviction behind it. Do it because you're really interested in that, right? Interested in that field, and that will take you in the right direction. And do you have protected time? So for me, I have a half day a week of protected academic time. Full disclosure, most of that goes to like working in a patient or there's an emergency. So I'm like, all right, just come up to the clinic and I'll see you then. So it's a time where I'm supposed to be able to do like academic work, but at least 50% of the time I'm dedicating it just to take care of your people. So some of that falls on your free time hours, but I've said this several times already. I don't mind it because I feel there's a lot of value both on what I'm teaching and what I'm learning, what I'm producing, whatever it may be.
I think people who are drawn to academics for sure want to teach and for sure want to maybe do some type of research.
There's one more piece.
Like if you want it, it's not necessarily like if that's what you want to do, like I think you're more drawn to that.
Yeah.
I'll say one more thing like that I considered is if you're in private practice, your primary job is being a clinician. Now you're in a different situation. You guys have med students coming through and things of that nature, but in a lot of private practices, it's your job is to be a clinician, see patients, turn things out, right? What the other part is that, like, for example, I'm on several committees. Like, one of the committees I'm on is improving diversity on our campus with our employees, our students, our staff. And if you're interested in doing other types of work and you realize you want to balance between just being clinical, I think the academic route gives you that. Because there are some people that will move to like a 50-50 line where they're doing a lot of admin and admin work and research work, and they're seeing some patients. So if you think you may want a little more diversity in your life, the academic world may be something you're interested in.
To kind of piggyback off of something what Nasser said earlier, is there are hybrid models all over the place. But one piece of advice that I got when I was a med student, in picking any job, any profession, the four things you got to take into account are money, passion, prestige, and free time. So the person who told me this was a psychiatry resident who it actually worked out well for me. So you have to rank those four things. Like, is passion, is your passion teaching, is your passion research, whatever that is, or wherever that ranks in the list for you, make sure you prioritize that with whatever practice you're in, like whether it's private practice or academic. If money is your number one driver, pick the job that's going to get you the most money. You don't have to say that out loud, but pick the job that's going to make you the happiest. So if you can like line those things up, if you can get your passion, prestige, free time, money, whatever order that you have that in, whichever practice that you're joining best fits that order, that's probably what's going to make you the happiest at the end. So that's one piece of career advice I usually give to people. It worked for me because in ordering my things, this job kind of lined up with the list that I had. And I think it works out well when your priorities are ordered. When it doesn't work out well is if you're doing something you're not passionate about, or you're passionate about something and it's not the job that you're doing. So sorry, don't want to ramble. I know we're kind of
I think it was a great point. And there's a Bob Rinaldi is one of our attendings and head of our pediatric department. He's great. And he said something during a lecture one time that's really true. He's like, go after what you're interested in. You talked about this, guys, your passion, because you're going to be fine. Financially, you're going to be fine. And of course, know your motivations. I think that's another really good point. But if you're doing something you don't like, all you'll think about, regardless of your money, is how do I get out of this thing? How do what's my next move? And no one wants to start their career that way, right?
Yeah.
Right. And if you're doing something you love, your patients can see that that will pay it forward. Like, right. They'll refer other people to you. And so you don't need to worry about, making money or anything. If you do a good job, like Nasser said, the money will come, you'll be fine.
I will say this. I had a previous career and I had some Sunday blues in my career. Sunday was come like, oh no, I got to go to work tomorrow. And I knew that I did not want to feel that way in life. Because we work too many days to feel that way in life.
All the time, I know.
It's not acceptable. It's not acceptable to be like, Sunday, I can't, oh God.
Right.
Yeah.
But I did feel that way. And I'm a pretty optimistic person. And
it's okay to feel like that every now and then, right?
And I don't have that, but as a physician, 90+% of the time, Sundays are great days. Yeah. And Sunday night's not a bad night either, because guess what? Tomorrow's gonna be a great day.
Exactly. Yeah. Majority of the days are great days.
It's such a blessing.
Yeah. Omar was asking Keston, I think that's a good question, being a sports medicine and what's happening with COVID and sideline medicine for your practice, how has that affected it? And then how do you think it will affect people in fellowship?
Oh man, so I was thinking about this recently. So in regards to my practice, our volume has been down. We have a big concussion program that I'm a part of at the Star as well. So when people aren't playing football or soccer or like training at all, that business has gone down a lot. For me, lucky enough that I do some of these lumbar procedures that so I can see like an older population. So what's kind of been buoying me a little bit is seeing like some of the older arthritic patients and things like that, like chronic musculoskeletal aches and stuff like that for right now. So sideline medicine, it's going to be tough. Their UIL which is like one of the governing bodies for high school sports in Texas. It's put out a bunch of suggestions, guidelines, regulations, whatever, about how to safely bring back football, and they're planning to do it. We will see if that plan remains in place. I have my thoughts, but it's been interesting. I think it's going to change it in regards, especially football, social distancing. Like the coaches are probably going to have to be masked. How much can you distance in a contact sport? We'll see. But
we're gonna play non-tackle football, guys.
Yeah, exactly. It has been
Non-touch.
Exactly. I mean, it's what I was going to make a joke, but again, my employer. I know it's an Omar question, so maybe I'll joke to him offline and say my. Never mind.
Right.
Let me not get in trouble. Again, the Washington D.C. in me is coming out.
Right. Off of Facebook Live.
couple of quick questions. Do you still perform EMG nerve conduction studies in your practice?
Nope.
You said no, Keston?
I don't. No, that was my choice. I had the opportunity to, and I didn't want to, so I don't.
Yeah. I do. It's just more of and it's not a right or wrong thing, but for me, it's just a service ad that I have for my patients. So if I feel that they would benefit helping diagnosis, I do. But I don't do it a lot. So I do.
That's why you and Sheena are the same person named Keston and I.
Yeah.
Like, no, don't do that.
I was like, I did my 200 plus, and I was like, I've had a good. I even did some in the fellowship, to be honest. Like I was like, oh, I thought like Nasser at the beginning. I was like, let me keep the skills up, and then I was like, why am I doing this? I personally just don't enjoy them. That's why I don't. But I don't call anybody who does. It is a needed service. I send people for EMGs all the time. I just don't.
All the time, right?
Sure.
Yeah.
So,
I don't do a ton. Just
How much ultrasound are you guys utilizing in your practice? I use a lot.
A decent amount for me too.
Mm-hmm.
On all types of stuff, especially when I'm trying to get a better look at a joint or an area of interest. Is this more arthritis? Is this more some subacromial bursitis in the shoulder? That kind of thing. I use it a pretty decent amount, like almost every day.
Almost every day, yeah.
How do you schedule your patients, Benecia or Keston? So if you're going to do diagnostic ultrasound, how much time do you allow for that visit?
I'm not doing a whole lot of diagnostic ultrasound. I'm using more mine for injection treatment. Okay. So mine's like spur of the moment. I'm like, okay, yeah. I'm like, yeah. Okay.
How about you, Keston? Do you do diagnostic?
Yeah, so not a ton, but I do. When I know that I'm just going to come and scan, I'll schedule them just for a diagnostic scan visit if I can. A lot of times, if I'm going to use it for a procedure, I just do a limited scan of the area of interest, or if I'm using it for an injection, I just do, again, a limited scan of the area of interest. But if it's a pure diagnostic scan, I put them on as a 30-minute just regular visit, just so I don't have to rush through it or feel like I'm going to get behind. Like I tell them that I'm like, if I wanted to take a comprehensive look at this, I don't want to rush. I don't want to rush you. So if you wouldn't mind coming back, we can do just an ultrasound visit.
Are you using it, Sheena?
I do, but not very often. More for like knees and shoulders, just for needle guidance. I do maybe 2 or 3 a week.
I would say that's where I'm at. Maybe some carpal tunnel as well.
Yeah, exactly. Yep. Yeah. All right, this is another good question since you guys both have residents. So how do you know when it's appropriate or when it's, you feel comfortable to let a resident do a procedure? Whether it's like a knee injection or, a ESI or. So
I actually run 2 Tuesdays a month. We have a resident fluoro injection day. So we do about 10 procedures throughout the day. And they're exclusive to the lumbar region. And so one of the things I do, and I was taught, actually when I was an intern doing central lines, and I had a resident who would sit me down, we'd draw things out, we'd look at the textbook, and we'd always make sure there was time for that and make sure we know what all the safety considerations are. And that's what I do. I pull out the textbook, we look at all safety considerations, and we spend about 20 or 30 minutes beforehand. And then there are some residents who are interested in injections and some residents who aren't. And so if they're not, no one has to be forced to doing certain types of injections either. So I get feedback on them, but it's usually lumbar, a good 20-minute teaching session beforehand. And then I let them know, hey, if I take over at any point in time, to redirect, don't take that personally. That's what we all go through. Just kind of set that beforehand. Like that's just part of learning. No cervicals. Rare cases would a resident do cervicals for us. But epidurals through, I had a resident last week who was driving RFA needles his first time and was doing it impeccably. So what about you?
So with me, kind of the same thing. Like I first check and see what their comfort level. Have you done this before? Are you familiar with the anatomy? If not, then I'll run through it with them before. For example, that resident that I was working with recently, we had a case of prepatellar bursitis. And just for symptomatic relief, yes, they recur sometimes when you drain them, but for symptomatic relief, she wanted it drained. So I'd done a whole bunch. You can do it blindly, but the resident said that they hadn't done a lot of ultrasounds. So I was like, hey, why don't we just throw it on here and, you know, see if we can do an image guided aspiration of it. She was down. So in there, I kind of let her drive. I'm like, this is how I hold it, or I'll give her like little pointers. I just introduced her to the patient, like, hey, this is Dr. So-and-so. She's gonna be doing this procedure. And then if there was any correction, like you said, I would kind of help drive for a little bit. But if I see that there's something dangerous happening, then I'm more apt to take over. And then the other times I try to just give little feedback, because I used to remember, like, if somebody just took it completely away from me, again, if within reason, like I'm not saying I don't want to hurt patients, and neither do the residents, but sometimes you kind of gotta mess around with it a little bit. I mean, as long as the patient's not, you know, in agony or getting an adverse outcome from it, to kind of get it. So that's the way I approach that situation. Again, I haven't had a ton of them. Nasser's probably seen a whole bunch more residents than I have. So if I get somebody who's driving the needle in a place that it shouldn't be, maybe I'll be, hey, let me maybe take this over instead.
I think for the residents out there, just as long as they feel, just they should always voice any concerns or questions they have beforehand, and not to think they have to fake it till they make it. Not with the procedure. It's just like, hey, if you have a question, let's talk about it. You're not supposed to know everything. And that's one thing about medicine. I think it's getting a little better. But you know, there's this idea you're supposed to know something before you've ever done it.
Yep. Everybody has
window. Reject that, man. Reject that.
Right.
Let's lose that.
We've all messed up plenty, right? It comes from,
yes.
That's where you learn the best, when you mess up and you're like, crap, I'll never do that again.
Never do that again.
Let me tell a quick story so my first day injecting at Desert Spine Sports, somehow I created my lidocaine, like numbing up the track and wheel, but I did that with the steroid syringe instead.
Because you use Dex, right? It's clear. So
it's not the best first impression. You're like, oh God, this is gonna be a long year with this guy. You know what I'm saying? So things happen, and that's the other piece. If something happens,
say something.
Communicate.
Oh, it happens. Yeah, it happens.
Communicate.
Nasser, are you and Sheena, are you either one of you guys doing any spinal stem trials?
I am not. I was trained in them at Desert Spine and Sports, but that's not something I am currently interested in, so I don't.
You doing any stem?
Yeah, so I am. It's going to be a small part of my practice, but if there are patients that have failed everything else, then it's something that we do. But it's not. I wouldn't consider my practice a STEM practice, and for people in spine knows what that means, right? But yeah,
right.
I think there are some areas of neuromodulation that we're continuing to learn about. So it could become larger. There are some other areas of movement disorders that neuromodulation is being looked at. So I want to keep the skills up, because you never know.
Yeah. Noel, I see your question. We're going to come back to it because it's a longer question, and I want to try to hit some of these other smaller ones real quick that we can answer quickly. Chait wants to know, Nasser, how have you not aged since medical school?
Chait, what's up, Chait?
Chait will be on it next month. Jasmine asked,
great.
do you have decided procedural days or intermix with clinic? For me, I have decided fluoroscopic days per month that's predetermined, and then I intermix my ultrasound throughout clinic. What about you guys?
Yeah, and I do spine injections almost every day of the week. So
Really?
it's like either in the morning and then I do clinic and then later in the afternoon I do it. So yeah, it's almost every day. But it's a mix. It's not a full injection day. I don't do that.
Yeah. Mine's just a half day a week so far as we build up, but I have clinic in the morning. So.
Mine's a full day, 1 day a week right now, and then I will work in patients kind of as needed if we can't schedule them on that day. And I'm in clinic or resident clinic or injection clinic with the residents the other time. So I think for me personally, I'd like to do about a day and a half. That would be, however that breaks down, that's usually probably the amount of injections a week I'd like to do. A day and a half. So I get asked this, and not to hijack this, but I do get asked this. There are some spine docs out there that inject exclusively, and their practice is set up where their mid-levels see their patients and they inject exclusively. And so
they're called needle jockeys.
Yeah, it's not really the model for several reasons that I want to pursue a practice, but there are practices out there like that. I would just say if that is your practice, you better have trained your mid-levels really, 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 really well to make sure that you're doing the right thing.
Just don't practice like that. Don't make it your practice. I'm just going to say that. Just don't do that. You didn't become a physician. Yeah, that's not why you became a physician.
So it's just a lot of radiation.
They're going to judge you. Donald asked Keston, did you find it difficulty coming straight out of fellowship, being in a practice without a more senior sports medicine faculty that you could go to? And if so, how did you try to combat that?
So while I didn't have somebody in clinic with me, Jim Sterling, he's technically one of my partners. He's been doing sports medicine for 20, 30 years. So he's always kind of a phone call away. I never feel alone. Like I've called my fellowship attendings. I've called Jim on occasion when there was something tricky. Like, I don't ever want to be on the news. Like, I don't ever want to be that doctor who did something crazy or missed something crazy. I don't want to be famous for that reason. So if I have a question and it's not something, I don't feel personally like that I'm alone. Like, I have a lot of mentors that are a phone call away.
Yeah, so, and we were on a group message with everyone we were in residency with, and we bounced stuff off each other.
Absolutely.
Almost every day. Yeah, all the time.
Now you're never alone. Even out there at Stanford, man.
Last question, Noel, from our audience here. So prior to COVID, what were your work obligations? Was it 8 to 5 weekends? Did you have to cover any local high school, colleges, pro sports? And then what do you envision your practice changes with COVID? So Benecia and I, we actually each made a video of our work weeks. So that's on our YouTube channel and our Instagram. So you can we went exactly what our week looked like kind of day by day. But what about you guys briefly, if you want to touch on that topic real quick?
Yeah, 30 seconds each, go.
Yeah.
All right. I'll go quickly. So prior to COVID, I don't know if anything's ever 8 to 5, but office hours 8 to 5. And some the difference now I would say is the use of telemedicine. And I think it's really great because we have a lot of patients that come from all over Texas or even regional patients. And it's been nice to help them, and in our immunocompromised patients as well. I'm doing intermittent telemedicine, but approximately half a day to a day a week right now. So that's been the biggest change. And I think we'll be able to utilize that moving forward too.
Yeah, pretty much what everybody said, have been mixing in telemedicine. I give all my patients the opportunity to get it. So if I have a patient in clinic, I'll do the telemedicine from clinic. If I have all telemedicine in the day, I'll do it from home. I am Monday to Friday, roughly 8 to 5, kind of like Nasser said. I was potentially going to start working with the team in the fall. There were talks about that, and then COVID happened, and so that kind of is up in the air. Like a lot of the Frisco schools have their doctors already. I was actually going to team up with one of the ortho surgeons and kind of tag team the responsibilities for the teams there. So I might have weekend responsibilities like a Saturday clinic eventually. I might do physicals outside of those work hours, but for the most part, I'm 8 to 5 Monday to Friday. That's it.
Omar says that he misses you guys, everyone, and he has invited everyone to Fort Worth, and he said dinner's on him. So.
Omar's the best. Not enough credit to go after him.
All right, last question from us, guys. We ask
everyone.
Last
question. Everybody. And I'm sorry, you go. Okay, I don't know. I got weird. If you guys were not, if you weren't a PM&R doctor, what would you guys be? And you can say medicine and non-medicine.
Go ahead, Keston.
Medicine have no idea. I honestly thought PM&R was the perfect fit for me, but non-medicine, that's easy. A couple of things. Instagram influencer with traveling stuff, pay me to be out on somebody's beach. I could do that. Or talk sports. Like I could be a talking head and spout off a whole bunch of stuff about sports all day at ESPN with her. Those would be the two non-medicine jobs.
Yeah, Keston and I we're gonna form a travel company. I'll do a travel blog and write Lonely Planet articles.
Mm-hmm.
Stay in like these hostels and give you these video blogs.
Yep,
I would do.
Love it.
Yeah,
I'm staying at a resort, but out.
And in medicine, man, thank God for PM&R, baby. Thank God for.
I agree.
But probably family, maybe a little sports influence. Probably, but thank God for PM&R.
Hey guys, this has been so fun.
This is fun. We could talk forever, but we got to end it sometime. So So thank you so much for joining us. You guys were awesome. It was good to see you guys, and thank you to our audience. Thank you for your excellent questions. This video will be up on our Instagram, our Facebook Live, and our YouTube channel. Also, don't forget about our podcast, where you can listen to this on Spotify and iTunes.
Thank you all for all you do.
Thanks for inviting us. You guys are awesome. This is really giving back. Really great job.
For sure.
How can they get in contact with you guys? If people have more questions.
Facebook.
So I'm on. Yeah. Oh, go ahead, Nasser. Go ahead.
No, Facebook or if someone has somehow you have contact with my numbers, or if somebody knows me, call me, text me. I'm more than open and happy to talk to anybody. So call Omar. He has my number. Call Omar. He has my number.
Yeah, same. Facebook. I'm on Twitter at DKESMD and Instagram with the same handle. So either of those places.
Yes, if you Google Dr. Robertson, it might come up Dwayne Robertson. So that is the same person.
That is the D for the DKESMD, Dwayne Keston Robertson.
Yeah. Very good. So next week, we're going to be focusing on a traumatic brain injury. So we're going to have a double header. We're going to have Dr. CJ Plummer at Vanderbilt. He's going to join us on Saturday. And then Sunday, we'll have Dr. Maria Polifron. She is a TBI fellow. And Dr. Mary Beth Phillips. She is a TBI attendee at Baylor. So guys, join us then. We appreciate it. You guys have a wonderful weekend.
Great week.
All right. Thanks. Y'all take care.
Thanks, guys.
See you, Facebook.